way. Thank you very much. And now we move to the third speaker, Professor Dr. Rasha Hassan Al-Awaidi, Associate Professor of Pediatrics and Pediatric Allergy and Immunology. Professor Rasha, beyond anything, she's a very devoted person, very honest, very active in our unit, and she's one of the important pillars in the unit. Very active, national and international. She's a member of the Egyptian Society of Pediatric Allergy Immunology, member of the World Allergy Organization, member of the European Academy of Allergy and Clinical Immunology, member of the European Society for Immune Deficiency and the African Society of Immune Deficiency. Now we're going to hear Professor Rasha Al-Awaidi. She's going to present the clinical picture of hereditary angioedema. تفضلي يا رشا. Welcome.
Thank you, Professor Shireen, for your kind introduction, and I'm actually honored of being your students, my dear professors. In my 20 minutes, I am going to talk about the clinical picture of hereditary angioedema, and let me first share with you one of our cases. This case is a 12-year-old boy, first order of birth of non-consanguineous parents, first presented to us at the age of 7 years with rapid onset of non-itchy swelling affecting the right upper and lower lid eyelids after simple trauma 1 day before. And the condition started to progress over the next days to extend to affect the whole side of the right face, and there was no response at all to antihistamines, steroids, or even epinephrine. And by the 4th day, the angioedema started to resolve by its own till completely faded by the 6th day. With follow-up, the patient started to develop recurrent attacks that increased in frequency and in severity, and the mother denied any history of relation of the attacks to food or drugs. And when we revised the family history of the patient, we found that he was born to non-consanguineous parents, and these non-consanguineous parents, the father had a similar history of recurrent attacks of angioedema that were affecting the skin, and he also started to develop in his adult years attacks of laryngeal edema and suffocation that ended to his death at the age of 28 years. And the mother history, the family history was irrelevant, but when we revised the history of the family of the father, we found that the father was also born to non-consanguineous parents. He has 2 brothers, the uncle of our index case. These 2 brothers were also affected with similar attacks of subcutaneous angioedema and also laryngeal edema. And the mother also had similar attacks of cutaneous angioedema. And one of the brothers and the mother also died. The brother died at the age of 31 years, and the mother died because she developed recurrent attacks of abdominal pain. Each attack lasted for a few days and were investigated, and nothing was found, and she was thought to be a psychic element. And then she developed one severe attack in which she entered into dehydration and shock and died in this attack. The remaining living uncle is now still living, and he has having recurrent attacks of also angioedema and sometimes laryngeal edema, but was undiagnosed till we noted to him the diagnosis of our case. And he is married to he is married and he's having a daughter, and this daughter is also having symptoms similar to her cousin, our index case. So on revising the family history, we found that there is no predilection to certain gender. Males and females are affected, and all of them are in the family of the father. So we are dealing with an autosomal dominant disorder. So the clinical examination of the patient at every time was normal, stable vital data, normal systemic examination, no evidence of anaphylaxis, only the non-pitting, non-tender angioedema of the face as described, and there was no ever history of urticarial lesions. So we realized that we are not dealing with a case of allergic edema. This case, every time the edema lasts for a few days, and the edema do not respond to anti-allergic drugs, including antihistamines, steroids, or epinephrine, and the attacks resolve by their own in addition to the significant positive family history. So we underwent laboratory investigation, including C4 and C1 inhibitor levels, which diagnosed the patient as a case of hereditary angioedema type 1. So what's hereditary angioedema and how diagnosis can be suspected? The hereditary angioedema is a rare and often debilitating form of angioedema associated with morbidity and mortality in the absence of appropriate intervention, characterized by recurrent episodes of transient, non-pitting, non-pruritic swelling of the subcutaneous layer of the skin or the submucosal lining of respiratory or GIT, and it's inherited autosomal dominant pattern. However, 25 of the cases lack the family history, which leads to the delay of their diagnosis more than those with positive family history. This type of disorders was first described in 1888, and the underlying biochemical abnormality was identified in 1963. And the estimated prevalence of hereditary angioedema is thought to be between 1 in every 50,000 to 1 in every 10,000 in the general population with no gender or racial predilection. However, it is suggested that the prevalence may be higher than that, but many of the cases go undiagnosed until very late. The hereditary angioedema typically develops in childhood with the mean age of onset 5 to 12 years, rarely occurs before the age of 1 year, and usually worsen during puberty and persist through the adult life. And it was found that the earlier the onset of the angioedema, the more severe the disease is throughout the lifetime. And in this figure, we can see the anatomical location of hereditary angioedema symptoms. The skin is almost totally affected in 100% of the cases. This is data from 221 patients with C1 inhibitor deficiency. And this is followed by the GIT attacks and followed by the laryngeal attacks. However, the angioedema also can affect other parts of the body, but with much less frequency, including uvula, tongue, brain, urinary bladder, chest, muscle, joints, kidneys, and esophagus. What about the clinical presentation of cases of hereditary angioedema? First, in some patients, there are prodromal symptoms, including tingling sensations, fatigue, asthenia, and discomfort at the site of the emerging swelling. Sometimes there are also serpiginous rash in the form of erythema marginatum, as we can see here in the figure, and this may precede the attack in 30% of the cases. And however, although it's specific to cases with hereditary angioedema, not with other types of angioedema, yet its presence was found to be associated with diagnostic delay, most probably because of confusion with urticaria. Sometimes when the mother describes that the child had an erythematous lesion before this, some doctors may interpret it as urticaria and not erythema marginatum, and they can only differentiate when they see the rash on the child or when the mother let them see the photos of the child. And this rash is evanescent, not standing for a long time, and that's why they may be missed by the physicians. In younger children, the erythema marginatum is described as independent phenomena and may occur without the angioedema itself, especially when they are in the newborns, as it has been reported in these two cases, erythema marginatum as an early symptom of hereditary angioedema. And in these cases, they were discovered to have hereditary angioedema only because they had positive family history, and that's why they were early investigated, and they found to have significant deficiency in the C1 inhibitor. What about the subcutaneous edema among our patients? Patients with hereditary angioedema usually have the edema affecting the extremities and the face more than the trunk. Here we can see the angioedema affecting the hand, and in this boy we can see on the left side, we can see how it's affecting the upper and the lower lids on one side. And in this boy specifically, he had recurrent attacks of rhinosinusitis, and in his first attack of angioedema, it was thought that this is a complication of the rhinosinusitis. But with the recurrence of the attacks and every attack of the orbital swelling stays for 2 or 3 days and resolve by their own and recur every few weeks, the physician started to investigate as he found that this is not related to the rhinosinusitis, and it was found that the patient had deficiency of the C1 inhibitor. So he was diagnosed as a case of hereditary angioedema. And this is important in order not to mix the cases in our clinical practice. What about the abdominal attacks? Abdominal attacks are the second most common form of the attacks. They result from the submucosal angioedema of the intestine. They are characterized by having significant pain, moderate or severe, usually colicky pain and poorly localized, and might be associated with tenderness as well. In addition, other symptoms might occur, including abdominal distension, nausea, vomiting, watery diarrhea, and dehydration, and even in some cases may progress to intussusception. And thus symptoms might mimic appendicitis, small bowel obstruction, inflammatory bowel disease, or gallbladder disease and diverticulitis, and may lead to unnecessary abdominal surgery. Also, the cases might be associated with elevated leukocytic count, so they might be diagnosed as case of abdominal infections or even FMF cases. And this is very important. So we have to note that not every case of recurrent abdominal pain is an FMF or a case of or abdominal disease or GIT disease. It may be a case of hereditary angioedema. And imaging in these cases using ultrasound or CT scan of the abdomen can show the presence of ascites or intestinal wall edema. In this CT scan, in coronal enhanced CT scan of a lady with hereditary angioedema, this
الصوت شوية.
obstruction. أفندم؟
صوتك كده كويس يا داليا.
The submucosal edema and the luminal obstruction and تمام. الصوت واضح؟
كده واضح، اتفضلي.
الصوت واضح؟
الصوت واضح كده، اتفضلي.
يروح ويرجع بيقطع بس.
تمام. And the coronal enhanced CT showed submucosal edema, and when she received the treatment of hereditary angioedema, the symptoms improved completely. And so it was recommended that recurrent acute abdominal pain of unknown etiology is a frequent complaint in pediatric emergency, and hereditary angioedema should be considered in the differential diagnosis. Concerning the laryngeal attacks, they are the third common form of the attacks in hereditary angioedema. Laryngeal edema is the most serious also, occurring in 50% of hereditary angioedema patients through their lifetime. They are usually occurs not during adolescence, but mainly during the adult years. It's the major cause of death with mortality ranging from 14 to 33%. Laryngeal episodes account for approximately 0.9% of all attacks. Over the patients are at risk of laryngeal attack, and more than 50% of the laryngeal attack have laryngeal attack during their lifetime. However, the lethal laryngeal presentation of the patient, and this is very important. Although the children are not liable to laryngeal asphyxiation like adults, however, asphyxia can develop in children more rapidly than in adults. They do not have the laryngeal attacks in the same frequency as adults, but asphyxia rapidly develops in them due to smaller diameter of their airways. And clinically, it does not differ from the allergic or the inflammatory airway edema. They may be diagnosed in the ER as a case of croup or having allergic angioedema. However, they are refractory to treatment using corticosteroids, antihistamines, and epinephrine. So we have to keep the hereditary angioedema in consideration in the differential diagnosis in order not to miss the cases. And in this figures, we can see here the laryngeal edema in a child with hereditary angioedema. On the left side, there is the angioedema attack, showing the swelling of the tongue, the laryngeal edema, and the obstruction of the airway. And this is comparison to the baseline of the child where the airway is clear after having the treatment. Fetal laryngeal attacks and mortality in hereditary angioedema, it was found in this study, including 70 patients asphyxiated of hereditary angioedema, that mortality was higher in patients who were undiagnosed than in diagnosed patients. And this is important. And that's why we are holding this webinar in order to increase awareness about hereditary angioedema, as it's important to save lives of the patients. Concerning the disease course of the hereditary angioedema, during the attack, there is gradual worsening over the first 24 hours and followed by even slower recovery over the next 48 to 72 or even 5 days. And the interval between the onset of symptoms and diagnosis has decreased from earlier reports of 22 years. There was a diagnostic lag of 22 years for cases of hereditary angioedema, and now it's about 8 to 10 years, which is still unacceptably long. What about the triggering factors for hereditary angioedema? Emotional stress is a very important factor. The minor trauma, whether a physical trauma or even dental work, infections, especially those of the upper airway, surgeries, medical procedures like endoscopies, drugs including ACE inhibitors or estrogens can increase the severity of the attack. And in adolescent females, the menstruation or ovulation also may precipitate the attack. And the hereditary angioedema carries significant burden on the patient, including physical and psychological and social effects due to the recurrent and unpredictable disfiguring painful attacks and the risk of suffocation. And in patients with untreated or inadequately controlled disease, a significant also impact on their school and social activities. And also those patients usually have higher levels of anxiety and depression in comparison to the general population. So the important message here is that in cases where there is angioedema without urticaria and non-itch lasting for more than 24 hours, non-responsive to antihistamines, corticosteroids, and epinephrine, with or without recurrent unexplained abdominal pain or positive family history, you have to consider the hereditary angioedema. Thank you. Thank you very much.
هتشكريها يا دكتورة شيرين؟
أقول لحضرتك يا بيه عشان تقدم دكتورة إلهام.
هتشكريها؟
أشكرها طبعا من قلبي دي يعني رشا بنتي. Thank you Professor Rasha Hassan Al-Awaidi for your excellent presentation. It's very important clinical picture. We have a lot of questions which will be after